This is Staying Healthy. The more you know, the more healthy you'll be. With us today is Dr. Bruce Porterfield, and we'll be talking about prostate cancer. Dr. Porterfield, welcome.
Well, I'm glad that you invited me here.
Well, I just noticed you're an MD and a PhD, so do you have to be called Doctor around the office?
No, I just have to remind people that I'm really not schizophrenic to have gone both routes.
That's absolutely amazing. How many years in college was that?
Well, it was the initial 4 years as an undergrad, and then your 4 years of medical school. Your PhD it depends upon what you're studying. And my PhD was in molecular genetics and cell biology. That was an additional 6 years for me. And then after you finish that whole process, so I did 2 years of medical school, then my 6 years of my PhD, I went back and completed the last 2 years of medical school. And then I did a year as an intern, 2 years as a resident, a year as chief resident, and then 3 years as a hematology oncology fellow and 1 year as a chief fellow.
So my guess is you'll have to live to 103 to pay your student loans.
No, actually, I was fortunate. My MD and my PhD were paid for through scholarships.
Wow. Congratulations. I'm impressed. Yeah. So I just read about a gentleman who was in medical school, and his school bills have gone over $1 million.
Oh, my goodness.
I don't know how that works out. But we're talking about prostate cancer today. And if we can just start with, what is cancer?
Cancer is a collection of mutations. So all of the cells throughout our body have learned what they're supposed to do based upon their genes. That's the footprint that tells the cells how to behave. It dedicates the cell to become a lung cell or a breast cell or a prostate. And so you have these genes that work together to tell the cells what to do. If you develop mutations, and that just means that there are abnormalities in those genes, then the cells will start misbehaving. Mm-hmm. As we're sitting here talking, we have cells that are dying and growing. And we have mutations that occur in some of those cells. Most of those mutations are lethal, and that just means that the cells are not going to survive. Or some of the mutations tag that cell as abnormal, and then your immune system will remove it. Cancer cells are unique. They develop mutations that allow them to grow even though they're abnormal cells, and allows them to escape the immune system. And so they can continue to duplicate, make more copies of themselves. So eventually you have one cell that's gone to 2, that's gone eventually to 1 million. Now you've got a mass. That's what a cancer is.
And so the mass would be a tumor?
That's a tumor. A tumor just means swelling. And so many people say, well, I've got this tumor. We want to know, well, what's in that tumor? What type of cells are in that tumor? Some tumors are benign. You can have a little lump on your skin, it's underneath your skin, and it may be referred to as a lipoma. It's just a fatty tumor. But that's benign. That's not a cancer. Cancer cells are aggressive cells that have mutations that allow them to really misbehave, and they will travel to places they're not supposed to be and start causing damage.
Now, with the prostate, what is the prostate gland? What does it do? And then we can get into prostate cancer.
So the prostate is a gland that sits just beneath the bladder. And the tube that drains the bladder to the outside, the urethra, passes through that. And the role of the prostate gland is to help make some of the fluids that get into your semen that helps the sperm to swim around. As we get older, our prostate will get bigger. So when the doctor does that digital rectal exam, he's waving his finger and poking it where you really don't want it. For men, he's feeling your prostate gland to see how large it is, to see if there are lumps or bumps back there. As we get older, guys start to complain about having to urinate more frequently. They can't hold their urine as often. They're not emptying their bladder as well as they did when they were much younger, or the stream takes a lot longer. That's called benign prostatic hypertrophy. As guys get older, their prostate gets bigger. That's why, as I'm getting older, it's becoming really real to me that occurs.
Well, it's become real to me.
As fun as I stand in front of, whenever I go to a public bathroom. I remember going to a public bathroom, and I walked in once, and there was a guy who's probably about 20 years older than I, who's already trying to urinate. So I stand in front of the toilet, and I'm trying to urinate, and then all these younger guys come in, and 2 or 3 of them leave before I do. But I'm leaving before this guy who is older than me. because that prostate, as it gets bigger, blocks off the flow of our urine.
And can it get so large it just totally blocks it?
It can. There are some guys who have huge prostates. They wind up in the emergency room because they have not been able to empty their bladder in a day or two, and they're having a lot of discomfort. And those guys will require a catheter to place into their bladder to help them urinate. Now,
I know that, and I've gone through many prostate screenings, but there's so many variations. Why is that?
So there are a variety of different groups that have recommendations about prostate screening. There's the United States Preventive Services Task Force. There's the American College of Physicians, the American Cancer Society, the American Urologic Society, the National Cancer Care Network. They all have variations on a theme. And that's based upon the fact that the studies that have been published regarding screening for prostate cancer are in conflict. There are a couple of European studies that suggest that early prostate cancer screening can help prevent you from dying of prostate cancer earlier. And there are some U.S. trials that are not as clear. They actually say that early screening can cause more problems and does not save lives. So all these groups are trying to find a way of at least encouraging guys who are at higher risk of prostate cancer into going through a screening process. All of these groups emphasize two things. They all emphasize that you have an informed discussion with your primary care provider. Mm-hmm. I think that's crystal clear. And then that, based upon that discussion you have with your primary care provider regarding your personal health history, your family health history, can help determine if and when you start screening. It's also clear when not to screen. So guys who have enough other health issues that they're going to die from those before they would ever die from prostate cancer, well, they probably should not be screened. Or if you're over a certain age, you should not be going through routine screening. And roughly that age is about 80 years old. Everybody accepts 80 is the cutoff. We should not be routinely screening 80-year-olds for prostate cancer.
What is the danger when you have a digital exam? You're talking about that specifically?
Now, screening involves, most guys are familiar with the term PSA, it means prostate-specific antigen. That's a blood test that we do. And that's an easy test. You go in, you see your primary care provider or whatever doctor, and they're going to draw blood, looking at your blood count, your liver, your kidney function, your cholesterol. So it's easy just to write for PSA. It's an easy test. And so that's a screening test for prostate cancer. Mm-hmm. The digital rectal exam is just another screening test. So the PSA is the blood test. The digital rectal exam is where the physician inserts his finger through your anus into your rectum, and they will feel your prostate. Mm-hmm. It's not a 100% effective test, nor is the PSA, because there are parts of your prostate gland that we cannot feel with our finger. Mm-hmm. Most of the areas that we can feel are the areas where most of these nodules or lumps are going to occur.
Now, you mentioned that some folks may be at higher risk if there is a history of prostate cancer in the family. Does that put you at higher risk?
It does. And so some of the risk factors that we can use to predict a higher risk of prostate cancer is looking at your family history, especially if you have guys who are diagnosed with prostate cancer earlier than the age of 60. That increases your risk, first and second degree relatives. And the more first and second degree relatives you have who are diagnosed with prostate cancer, the higher your risk. African Americans are at a slightly higher risk of aggressive prostate cancers, not necessarily more, but aggressive prostate cancers. And then if you have a PSA that's rising quickly, that can also increase your risk.
So if my brother had his prostate cancer in his 50s, so that would put me at higher risk?
That could increase your risk.
Wow.
Now, something else that's also important, if you have family members with other types of cancer syndromes, in particular women, if you have members of your family who have had breast cancer or ovarian cancer, that might also increase your risk, especially if they have a documented genetic mutation called BRCA1 or BRCA2.
Now, with the PSA, I know basically where mine runs, But I have friends that have a much higher PSA but no cancer. So how do you figure out how your number is relative to that cancer?
So the PSA can be elevated for other reasons. One reason that the PSA is elevated, as we get older and our prostate gets bigger, our PSA can go up. So everybody wants to know, well, what is a normal PSA? Mm-hmm. The normal threshold, upper limit, is 4. Once you start getting above 4, it starts raising our suspicions that you might have prostate cancer. But as we get older and the prostate gets larger, our PSA can go up just because we have a large prostate. We may not have any cancer, just a big prostate. That's one thing that can raise it. If you have inflammation or infection of your prostate, that can temporarily raise it. If you had a digital rectal exam that was done just before your PSA was drawn, that might raise it a little bit. If somebody had catheterized you or done a biopsy of your prostate, that can temporarily raise it as well.
Now, can the biopsy be more accurate than the PSA or the digital rectal exam?
The biopsy is the more accurate of the 3 tests, because the biopsy is if you do have prostate cancer, it's more likely to find it. But you can have prostate cancer that is also missed by a biopsy.
Really?
Yes. So it's not a completely accurate test. So many guys, when they've had a biopsy, they will tell you that they took 12 samples. And in those 12 samples, some guys, all 12 will have prostate cancer. It's because their entire gland is filled with cancer. But some may only have 1 or 2 of those cores where they find prostate cancer.
Now, you mentioned there's some parts of the prostate you can't get to when you're checking it with a digital exam. Does that hold true for when you're grabbing a piece of the prostate to check it for cancer?
They can do a more thorough evaluation of your prostate with the biopsy, mm-hmm. because that's going to go deeper than my finger can ever feel.
Mm-hmm. It just in terms of those 3 tests, can you get maybe a 90% determination of the prostate possibilities with cancer?
I'm asking for
every man in the.
It's actually not quite that high.
Really?
Yeah. Now, the higher the PSA, the more likely you are to feel a lump in the prostate, and then the more likely you are to have a biopsy that's positive. So if a guy has a PSA that's 6, and you may not he may have prostate cancer, but you may not feel it, because he may have an early stage of prostate cancer. When you do the biopsies, you might actually miss it the first time if he's got just small microscopic amounts of cancer. And that guy might require another series of biopsies in a year or 2 years. So you follow the PSA, and as the PSA goes up, it tells you that the cancer is growing. Eventually, you might feel it. And if you can feel it, then the success of the biopsy is going to be higher. But if you can't feel it, the success of the biopsy, if the PSA has gone up, is still going to be higher than doing the digital rectal examination.
So it's in the 80 to 90 range? I'm trying to pin you down here.
It's probably more in the 80 range.
Yeah.
It's not in the 90 range.
Do you know what the current statistics are of surviving prostate cancer?
Yeah. For surviving prostate cancer, the statistics are good. This is a slow-growing cancer, unlike a lung cancer or colon cancer that grow fast. Prostate cancer can be a slow-growing cancer. There are some guys who may exist with their prostate cancer for a couple of decades, untreated, and die of something completely unrelated to prostate cancer. So prostate cancer is a second cause of cancer in men. It's second to non-melanoma skin cancers. But it's not the leading cause of death. It's the second cause of death after lung cancer. Approximately 200,000 men are going to be diagnosed with prostate cancer this year. Maybe 20,000 of those are going to die of prostate cancer this year.
So that's about 10%?
Yeah.
And is your prostate affected by diet, or any challenges like that?
It might be. The influence of diet on all cancers is unclear. There were some studies that were done, decades ago, and these studies looked at some particular nutrients that were in the soil, and one was selenium. And selenium is a micronutrient that's found in the soil. So it's also going to be found in food products, mostly crops. And so there were some epidemiologic studies that were done, I want to say 30, 40 years ago. And what they found is that people who lived in regions where there was a lot of selenium in the soil seemed to have a lower incidence of certain types of cancers, and prostate cancer was one of those. So this led to clinical trials to see if this was indeed true. And so Larry Clark, who was one of the investigators here at the university about 2 decades ago, he did a study with people who had non-melanoma skin cancers, and he treated them with selenium. And he wanted to know if there was going to be a lower incidence of these non-melanoma skin cancers in these patients. And there wasn't. It had no effect on their skin cancers, but there was a hint that perhaps it reduced the incidence of prostate cancer. So that led to a huge study. It was called the SELECT trial. And they randomly assigned guys to one of 4 different groups. One group got 2 placebo pills. Another group got a selenium capsule and a vitamin E. Another group got just selenium and a placebo, and the other group got vitamin E and a placebo. And the expectation was that the group that had selenium would have a lower incidence of prostate cancer. Well, it was not effective. So selenium, even though there was a hint that selenium might reduce the incidence of prostate cancer, hasn't borne fruit. Another one is beta-carotene. That has also not borne a lot of fruit. That if you start taking beta-carotene tablets, it's not going to reduce your risk of prostate cancer. It's probably a combination of micronutrients that are in the diet that you just cannot duplicate in the capsule. So if you're eating a well-balanced diet, there may be a reduction in your risk of developing prostate cancer and other cancers. There have been some dietary studies where they have treated patients with a variety of different types of cancers with certain diets. And they do find that patients who have a basically healthy diet, and that means a low caloric intake, they're not consuming a lot of red meat. There's an emphasis on fresh fruits and vegetables. Now we're talking 6 servings, a minimum of 6 servings of fresh fruits and vegetables. Those patients seem to have a lower incidence of certain types of cancers. Prostate might be one of those.
Now, that would be a Caribbean type diet you're talking
Mediterranean.
about? Mediterranean.
Diet, right. Yeah, exactly. The Mediterranean type of diet. The Mediterranean diet also adds in alcohol, though, as I recall. Alcohol might not be the best thing for cancer patients. There's still a lot of controversy about the role of alcohol in cancer.
Mm-hmm. Now, let's say you go through the 3 steps. You have a digital exam, and then you follow with a PSA, and then follow with a biopsy, and they all show something. What's step number 2? So they all show something, and that means you've got prostate cancer. That's essentially what you're saying, because the biopsy is going to be the confirmatory test. Mm-hmm. So if it's positive, you have prostate cancer. What you then want to know is, what is my Gleason score? Gleason.
The Gleason score.
How do you spell that?
Gleason. And the Gleason score predicts how aggressive your prostate cancer is.
How can they do that?
Well, they look at the cancer cells under the microscope, and they'll rate them based upon how much they look like normal prostate versus how chaotic they look. And they'll give them a score of 1 to 5. And they're going to look at 2 different areas, and so you're going to get 2 scores. And so the maximum score will be a 10. The lowest score is a 2. So what you want to hear from your urologist who does a biopsy is that you have prostate cancer, but your Gleason score is 2. Mm-hmm. And so we then divide these Gleason scores into risk categories: low risk, intermediate risk, and high risk. And it's based upon the total Gleason score. So the 2 areas combined together. A score between 2 and 4 is considered low risk. If you've got a score of 2 or 4, you probably don't need to do anything more than just have somebody follow you routinely.
Now, can you put a number of years on that?
Yeah, that's the sort of person who's probably going to live for the next 20, 30 years and not die of the prostate cancer. The next group are the intermediate risk group, and they're going to have a Gleason score of 5, 6. Some of the 7s are going to fall in that category too. Those folks, you're going to have to watch them a little closer. At some point, they may require some type of intervention. The worst score are those who are 8, 9, and 10. And some of the 7s. But 8, 9, and 10, those are the most aggressive cancers. Those folks are going to need to have some intervention now. And we can talk about the different things we do here in a few minutes. But those are the folks who, unless they're old enough, you're probably not just going to sit on those. You're going to do something to reduce the risk of their cancer spreading and eventually claiming their life.
Now, everybody would like to go out and say, is there a pill for this? And maybe there is, maybe there isn't, but once again, we hear all these different stories, especially when it comes to the removal of the prostate gland.
So how do you treat prostate cancer?
Well, I just, that alone scares me.
Well, for some guys, especially if they're young and they have an aggressive cancer, they really do need to consider surgery. They may also require radiation after they've had surgery. And some of those guys, we need to suppress their testosterone. Prostate cancer feeds on your testosterone.
You're stealing my thunder. I was going to say, is there different ways you can measure the testosterone?
Yeah, it's a simple blood test.
Really?
Yeah, it's just another blood test. And so we want to, if it's localized disease, you want to manage it locally. Surgery, radiation, a combination of the two. For more aggressive cancers, like those Gleason 8, 9, and 10, that predicts the fact that those folks, their cancer might have already spread at the time of their diagnosis. So some of those individuals, you're not only going to do surgery and or radiation, you may also treat them with medications temporarily that's going to reduce their testosterone. So if the cancer had already spread before the local therapy, you're going to suppress the growth of those cells wherever they are. When we're treating those guys, it's not a pill, it's a shot they get.
Really?
Yeah, it's a shot.
And what's that include?
They come into the clinic, they say hi to the nurses. The nurses tell them to expose their belly or their butt, and they inject them with a drug. And a common one that we use is a drug called Lupron or Leuprolide. And you can get that as a shot once a month, once every 3 months, once every 4 months, or once every 6 months. And what that shot does is it suppresses your body's production of testosterone.
Mm-hmm.
It comes with some side effects. One of the most common side effects that guys will complain of are hot flashes. Because, they will have hot flashes. Just as their wives who are going through menopause have hot flashes, they will. And sometimes the hot flashes are pretty profound. I had one guy who came in to see me, and he said he was having 15 hot flashes a day. Yeah.
Oh, my goodness.
It gets better. When you first get the shot, that's when you're going to get most of the side effects. But the farther you get away from the shot, the side effects start to decline. And then the next time you come in for a shot, it may not be as bad.
Now, does it stop the cancer or just maintain it at the level that it's at?
For some guys, it actually stops the cancer. Because the cancer requires testosterone to grow. Mm-hmm. So if it's and reproduce itself.
So you're taking the food away.
Correct. You're starving the cancer cells.
Great.
And so you're going to have some side effects from that. Again, the hot flashes are one. Men can also start developing breast, which can become tender. And men require testosterone to maintain their muscle tone. Mm-hmm. And so you start getting some muscle wasting, some muscle weakness. So guys can feel tired from this as well.
Now, what about performance?
You mean sexual performance?
Yes.
You're going to become impotent with these shots. Now, any of these therapies can cause impotency. Surgery can cause impotency because they're going to potentially cut through some of the nerves that allow a man to get an erection. Radiation is going to also affect some of those nerves. They may recover if they have had radiation. It's less likely to recover if you've had surgery. When you go on these testosterone reducing agents, you're going to become impotent as well. If if you weren't impotent before you started those shots, if you stop the shots, then your sexual function might actually recur. I mean, be restored at some point in the future.
Now, we can talk about the recent advances. Are there some that don't have such drastic reactions?
Yeah, there are some. Most of the newer advances that are being done for prostate cancer, I'm going to lump them into two categories. One is who to treat.
Mm-hmm.
And the other is you have somebody who has cancer and they need treatment, what to do. And the mainstay of treating advanced prostate cancer are these hormone suppressive shots. But not everybody needs to have these shots all the time.
Mm-hmm.
For some guys, you give them the shot on an intermittent basis. You reduce their PSA. You can hold the shots until their PSA starts to
rise again.
And in that interim, their quality of life improves.
Mm-hmm.
And then their PSA goes up, and you have to decide again, is it time to retreat? Their PSA will drop, and they'll have some period of time where they're having side effects. But when they have that break from the shots, again, their quality of life improves. So there are other guys who have to remain on these shots all the time. But then there are other guys who are now putting on pills.
Mm-hmm.
Because you'd ask about that.
Yeah.
And there are some guys you could put them on pills. Not everybody goes on the shots, but you could just start them on a pill, especially for some of the older guys who are a little more frail. You may want to just start them on a pill, and they may do much better as far as their quality of life.
Now, what if you leave prostate cancer untreated?
So that's the other group. This can be a slow-growing cancer. And when the PSA was first discovered in the 1990s, there was this uptick in the diagnosis of prostate cancer because we started using it for screening. Initially, it was used as a way of monitoring how we treat it and how patients respond and whether they relapse. But then when we started using it for screening, we started identifying more guys who had prostate cancer. Not that there was more prostate cancer, we were just identifying them. That led us to start treating. And I think that we realized that we were over-treating. Mm-hmm. Some of these guys who have low-risk disease didn't need to be treated. They just need to be watched. And I think that's the new advances that we are starting to establish with prostate cancer is learning how not to treat, but how to watch. Because some guys, they're going to live a normal life. They're going to die of something unrelated without any complications from their prostate cancer. But we can have a detrimental impact on their quality of life if we treat them when they don't need to be.
What about the seeds, the radiated seeds?
That's for guys who do need to have their prostate cancer treated, and they either don't want surgery or they're not a surgical candidate. The radioactive seeds are one way of treating them locally. They inject these seeds directly into the prostate gland. And those seeds are embedded with radiation. And so you get this local radiation spread to the prostate. For some guys, that's all they require because they have a low burden of disease. For some guys, they will require the seed implantation, but they will also require what's called external beam radiation, where you lay on the table and they're zapping the prostate every day for about 7 or 8 weeks.
Now, do you feel the seeds are effective?
For some guys, it's very effective. There are some guys who only had seed implantation, and that's all they ever needed.
Now, can you remove a portion of the prostate without challenging the effectiveness of the prostate?
Yes, you can. Again, if you have a guy who has a low burden of disease, it's limited to, when you do the biopsy, you find it's limited to one lobe of the prostate. You may only do a partial prostatectomy where you only take out half of the prostate.
Does it grow back or you just work with half?
You'll just work with half. But when you're at that point in your life, your prostate is not as functional as it was when you were younger.
Mm-hmm. You're making this a very cheery, smiling discussion here.
I'm starting to learn that personally.
Yes, we all are. Let's review then. At what reasonable age, unless there's a history, is what you're saying, should you get your prostate checked?
That's still part of the debate, whether you even need to have it checked. But
where do you fall on the debate?
So where I fall on that debate, if you're going to have your prostate checked and you don't have risk factors, start doing it around the age of 60.
Really? That late?
Yeah, unless you have high risk factors, you really don't need to check that frequently. Some will argue maybe start doing it at 50, but definitely by 60. If you're going to do it, then you have to make a commitment to do it routinely for a while.
Now, in terms of research going on right now, what are you aware of?
Most of the research now is focused on treating advanced stage prostate cancer.
Makes sense.
Right. And so I think the hot topic in the cancer community and as well as in the lay community are what we refer to as immunotherapies. Mm-hmm. And these immunotherapies are stimulating your immune system to become involved in treating the cancer, whatever type of cancer it is. And that's where we're moving with managing advanced stage prostate cancer, is these immunotherapies. And in some instances, they're better than chemotherapy. They come with a variety of different side effects, but they can be more effective. Sometimes you use them in addition to chemotherapy or hormonal suppressive therapy.
Now, that's placing cells in the body? And
No, actually it's not.
Oh.
No, that's stem cells. With the immunotherapies, in some cases, you're giving a patient an infusion of antibodies that will recognize abnormal molecules on the cancer cells. And think about these molecules as a targeted way of attacking the cancer cells.
Sort of medical Pac-Man?
Correct. I mean, that's a good analogy. It's a medical Pac-Man. It goes directly after the cancer cells, kills those off. There are some side effects, but nothing like what you see with chemotherapy. Another approach is giving a medication that stimulates your immune system so it now recognizes the cancer cells as abnormal. And so now your immune system will take out the cancer cells.
And will they take out all cancer cells, or are they able to just focus on one section?
They're going to focus on cancer cells that have unique genetic abnormalities. So for some of these cancers, we are actually testing the cancer cells for unique genetic abnormalities. We call that molecular profiling. It takes a little extra time, but it's actually worth it. I mean, patients, when they're diagnosed with cancer, they're anxious. I mean, I understand that. They want to take care of this. They want something done. But now as we start moving into this new era, we call it precision medicine, where we're not just doing this shotgun approach with chemotherapy, which causes lots of side effects. We're actually trying to target your therapy. And the immunotherapies are one way to do that. But we know that you have prostate cancer just from your biopsy. But we don't know the molecular details of your prostate cancer. We have to send that to a genetic profiling lab. It takes a little extra time, sometimes a couple of weeks. But that couple of weeks, it causes anxiety while the patient waits. But it can be worth the wait because it can give us specific details about what is the best way to treat your cancer with fewer toxicities.
So the bottom line on prostate cancer is what, if you can wrap this up in 60 seconds?
It's a slow-growing cancer. Not everybody needs to be screened as aggressively. Screening needs to start with a detailed discussion between the patient and their provider, whether it's their primary care provider or a urologist. You need to have a detailed discussion of what the risks and benefits of screening are. Once you've embarked upon that decision to screen, at whatever age, then you have to make a commitment to periodically go through the screening. After you are old enough, you don't need to continue to screen if you don't have prostate cancer. If there is a suspicion you have prostate cancer, you have to understand the risk and benefits of the biopsy. Once you have a diagnosis of prostate cancer, it's important that you remember what your Gleason score is, because that will predict your prognosis. That helps determine whether you need to have your cancer treated or just watched.
We will talk more with you as the year progresses here, and we thank you for your time. Very interesting. You scared the daylights out of me now.
Sorry.
And I imagine there are going to be hundreds of men running to their physicians saying, "What's my Gleason score?" So
well, only if they've had a biopsy. If you've not had a biopsy of your prostate, don't ask.
All righty. Dr. Bruce Porterfield, Arizona Oncology. This has been Staying Healthy. The more you know, the healthier you'll be.